Your teenage child has been diagnosed with functional neurological disorder, short for FND, and you might be having some trouble with school as to what you can do to work with the school to help your child recover and thrive in this school environment. Well, I have a good news for you. I just made this webinar specifically addressing what school can do to support your child through this recovery. So without further ado, enjoy. Hello, everyone. I am Dr. Lee, and I am thrilled to invite you to a special webinar. Today, we will explore how schools can best support students with functional neurological disorder, short for FND. Join me for Teen FND, the ultimate guide for school, where we will share insights and practical strategies to empower our students. Let's get started. Hi, my name is Dr. Lee. I'm a pediatric health psychologist and chronic pain survivor myself. My mission is to help teens and their parents resolve persistent physical symptoms such as chronic pain and FND so that they can get their life back and feel like normal again. Because I truly believe that these teens struggling with particularly FND deserve so much better in their lives. As part of my mission, I founded the Teen FND Academy, a skill-based online program to resolve teen FND. In this webinar, you will be learning 4 things. Number 1, to understand unique challenges and impacts of FND in pediatric populations. Number 2, to differentiate the common causes and underlying mechanisms of pediatric FND. Number 3, to identify collaborative care models to effectively address the complex needs of children with FND. To apply skills in assessing and addressing biopsychosocial aspects of pediatric FND in school. I'm going to start with a story of Megan, who was a competitive dancer now diagnosed with FND. She was a 16-year-old competitive dancer, and at baseline, she was a little bit anxious, but she was a high-achieving straight-A student with good friends and family. Until one day, she fell and had a concussive injury. Since then, she has developed daily headaches, which led to visiting so many different doctors with lots of medications with absolutely no progress. And when she has worse headaches, she would go to multiple ER visits for rescue medications. Every time she goes to ER, she gets CT, MRI, and blood work, and more tests, which all came back negative, which means there was nothing that doctors can find. 3 months post-injury, she's having ongoing headaches, but now she's having these frequent faintings and seizure-like symptoms. As a result, she saw physical therapists, chiropractor, acupuncturist, massage therapists, functional medicine doctors, you name it, anyone under the mother, which gave Megan some temporary relief, but she's still having ongoing symptoms. Fast forward 1 year post-injury, she's still having symptoms and now adding a new symptom of weakness in her legs. Her family took her to another neurologist for second opinion, who told Megan, everything looks great. You have functional neurological disorder. Go see a psychologist. At this point, Megan's daily functioning level is pretty bad. She's hardly attending school, falling behind in school. Her sleep is disturbed and socially isolated, including not dancing. She's feeling depressed and more anxious, and now she's having family conflict. Megan is thinking, extremely frustrated and disappointed. She can hardly go to school, missing days or coming home early. She's feeling sad about missing out in life, especially compared to her peers. Her sleep is terrible, but most importantly, she's worried about the future. What if I don't get better? Her mom is just as frustrated, but desperately wants to help Megan. She's anxious about Megan's future, and she's also upset about not getting clear answers about Megan's condition of this new diagnosis of FND. And she is also feeling helpless about not knowing how to help Megan. According to the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, aka DSM-5, FND is defined as having these criteria. 1 or more symptoms affecting body movements or senses, and symptoms cannot be explained by other neurological, other medical condition, or mental health disorders. And symptoms cause significant distress or problems in social, work, or other areas, and they are significant enough that medical evaluation is recommended. Now, FND has so many different names, including functional neurological symptom disorder, which is the newest term according to DSM, used to be also called convergent disorder, including hysteria. Not only the names, FND also has so many symptoms, including seizures, paralysis, fainting, numbness, weakness, tremors, brain fog, vision loss, speech loss, tics, balance problem, inability to walk, chronic pain, muscle tension, you name it. And way back when in the past, FND was considered a diagnosis of exclusion, which means the doctors will run all kinds of tests they can imagine and they cannot find anything. Therefore, what is just left is the diagnosis of FND. That is old news and it's not like that anymore. In fact, FND is a diagnosis of inclusion. So, how do doctors diagnose FND? Well, they go through physical exam, depending on what's going on. Includes Huber's sign and motor inconsistency is what they're looking for. They're also looking for sensory signs such as non-anatomical sensory loss, inconsistency, or changing pattern in sensory losses, and systemic failure. And typically MRI, CT, EEG, blood work, X-ray, all are negative. Of course, doctors are spending a lot of time providing clinical interview, and diagnosis is made by typically neurology, mostly to rule out other concerns, either in the clinic outpatient setting or in the ER situation. Now, as I mentioned, FND was used to be considered a pure mental health disorder, which was a conversion disorder. However, since then, things have changed a lot. And now FND is a biopsychosocial phenomenon. So I'm going to talk about biological factors. Prior physical injury, such as car accident, concussion, like what Megan had, whiplash, and etc. Could be any kinds of illness, brain functioning, increased resting heart rate, hyperactive arousal, sleep problems, poor eating habit, fatigue, temperament, IQ, and family history. And then psychological, it could be trauma, anxiety, depression, ADHD, autism spectrum disorder, sensory processing disorder, belief system, coping skills, and mindset, and you name it. And of course, we cannot talk FND without talking about social, including friends, family dynamics, school, extracurricular activities, social skills, parenting styles, hobbies, cultural expectations, social expectations, and behavior reinforcement. Now, this is one of the scientific evidence showing that FND is not just psychological or not real. It is very real. And based on several brain scans, researchers actually found something discretely different about patients with FND's brain functioning compared to others with no FND diagnosis, including hypoactivation, which means down activated of dorsolateral prefrontal cortex, the right temporal parietal junction, and angular gyrus. So all linked to a low sense of control, sense of agency, motor problems, and memory problems. Additionally, there's hyper, very activation of the amygdala, insula, and the anterior cingulate cortex, which all link to a high level of anxiety, perceived stress, and high level of pain sensation. Of course, and also there is a hyperactivation of something called mirror neuron, which is included as a high level of empathy towards other people. So some might say that they're emotionally sensitive because of these physiological reasons, and also influence on movement from observation, talking about functional tics and TikTok tics. And some may wonder, functional tics, speaking of which, a part of FND may or may not be the same as tic disorder. So let's take a look at this chart here. With FND or functional tics and Tourette's, typically they're teen onset and they're more commonly happening among females, and they are having hard time suppressing these symptoms and having less of this urge prior to having these symptoms. And typically speaking, medications do not help. Versus typical classic tic disorder, younger age onset, more likely happening amongst male versus female, and the course is gradual. It's not abrupt and complex in the beginning. Teens with tic disorder can functioning daily normal activities, and they can also suppress to a certain degree, but most likely they will experience this urge before they have these symptoms. And medication can be helpful for this tic disorder. And what about non-epileptic seizure versus epilepsy? Non-epileptic seizure is the most common type of FND, as I mentioned, and oftentimes people mistake NES as the same as epileptic seizures. Because of the knowledge we have about NES today, many providers actually don't use the word seizure, quote unquote, to describe FND anymore. Instead, they use non-epileptic attack or non-epileptic episode to differentiate from epileptic seizures. And so this is a list of what non-epileptic attack or episode looks like. This is not an exhaustive list or definitive, as everyone's symptom can be different. So that's the caution. Let's just look at this. Inconsistent or changing patterns of symptoms every time they have these quote unquote non-epileptic attack or episode. Episodes can last for more than 5 minutes or hours sometimes. Eyes can be closed or rolled out to the back. Tongue biting can happen, and this jerky movement of almost tonic-clonic or convulsive episode of seizures might be looking like this non-epileptic attack. Twitching arms and legs for 2 minutes or more can happen, and sudden emotional outbursts can happen. Gradual building and hyperventilation can happen associated with non-epileptic attack or episode. And there might be a clear consciousness after an episode like nothing happened, or they might feel very exhausted and tired. And less episode when they're alone, that doesn't mean they don't happen, but it can be like this. And less injury can happen during episode. The incontinence is actually pretty rare. FND is historically considered a mental health problem because of childhood trauma, like when we used to call FND conversion disorder or hysteria. That is old news, but applies to many adults who are diagnosed with FND. For example, statistics says that adults who are diagnosed with FND, more than 90% can have a trauma in their childhood, versus pediatric FND is different. This is why we cannot think of children as small adults. If you think your child FND is purely related to trauma, it may or may not be true, because a statistic says the pediatric FND is less than half of the percent related to having any kinds of trauma. And these are common phrases students with FND hear, and they are called medical gaslighting. They are straight up rude, invalidating, and cruel. So if you hear others, such as your colleagues or somebody else, say these things, please gently educate them about the impact of these medical gaslighting phrases on the students with FND, such as, it's all in your head. There's nothing wrong with you. That's great news. It's a teenager problem. Your child is making things up. We don't believe your child. It's all psychological. It's all stress or trauma or anxiety, or it'll go away in X month, or you look fine. Others don't look like you. This is permanent and you will live with this forever. I mean, how invalidating could that be? Now, let's move up the gear and talk about the mechanism of FND. And in order for you to understand FND, you have to know the 3 Ps. Number one is the predisposing factors. It is something that was cooking inside the oven for a long time, so such as genetics, family history, baseline medical conditions, baseline emotional or psychosocial issues, and all that kind of stuff can go into these predisposing factors. And then there's a precipitating factors. This is usually the trigger. What triggered the student to have these FND symptoms to begin with? So for Megan, it could be the concussion, the injury that she had, and that precipitated pain led to FND symptoms and diagnosis. And then there is this perpetuating factors. Perpetuating factors are something that isn't necessarily the reason for having these FND symptoms, but why symptoms of FND are continuing to exist. So think of a fire. What is the oxygen or the gasoline for the fire of FND to continue? That is the perpetuating factors. And in addition to the 3 Ps, it is essential to understand our 3 states of the nervous system, which all have. Number one, on the right side is the fight or flight, also known as the sympathetic nervous system. This is when a student may look irritable, on edge, hyper-focused on something, or avoiding something, or anxious, or experiencing the pain. All the way to the left side of the frozen, which is too much parasympathetic nervous system, where the student may look like withdrawn, dissociated, having a syncope, aka fainting, feeling paralyzed or having this paralysis, or feeling numb, depressed, and having FND symptoms. Depending on what kind of FND symptoms that they're experiencing, they can be either on the frozen side or too much of the fight or flight side. And then there is something in the middle where a student would be feeling calm, feeling socially connected and happy and joy and feeling relaxed. Now, none of us can stay in this calm state all the time. We are bound to bounce between fight and flight and frozen and then kind of going back and forth between all of these states. However, everyone has some sort of a familiar state where, for example, Megan's familiar state can be on a fight or flight. Why? Because she has this anxiety baseline and high achieving and high strung, straight A student, very competitive, and those are needing this kind of sympathetic nervous system activation to get going. But sometimes if it gets too much, nothing of too much is good. So this is where you want to be flexible to go back and forth between different states. Now, let's talk about how FND is treated. As an education system, your role is not to provide medical treatment on site, but because you have students on campus, it is extremely important for you to know how FND is treated. Number one is the accurate diagnosis. This is all we start. Usually, once again, by neurology with scientific tests and interviews. So then we are sure that this diagnosis is indeed FND. And then both family and school, that includes you, need to understand and accept the diagnosis. The time for you to stick to the student lying or faking is simply gone once the students get this diagnosis. If you're not on the same boat, then you could be the perpetuating factor for the student having FND. Therefore, you have to be working as a team between the family and the providers who are providing this diagnosis. And then regaining the daily activities, that includes going to school, becomes absolutely critical towards the recovery of FND because it's a functional neurological disorder. Focusing on improving and regaining the function of daily activities is the essential ingredients for the treatment. And then, as I mentioned, FND is a dysfunction of the nervous system. Therefore, rebalancing the nervous system becomes absolutely critical. And then retraining the brain for the student is absolutely necessary once they are able to regain the daily activities and rebalancing the nervous system. And in order for them to go through this treatment roadmap, FND recovery has these two absolutely necessary ingredients from the child. One is a sense of control. In other words, empowerment. These students with FND are already feeling less of control or less sense of agency. Therefore, it is really important for the children to start to regain the sense of control, and so they feel like they are back in the game. At the same time, they absolutely have to have their self-awareness, not just about the symptoms and how things are bad, but everything else, the way they think, the belief system, all kinds of triggers and warning signs and everything else need to be put in on the conscious level so that they are aware of exactly what to look for and what to do. Speaking of the resolution, as I mentioned, students' FND cannot get better without the involvement of school and provider. There is a phenomenon called spontaneous recovery, and it's true, where kids can get better without not doing anything. But unfortunately, without learning skills to manage or resolve the symptoms, 2/3 of these students who had spontaneous recovery are bound to have a spontaneous relapse, which means these symptoms come back in the future, usually with vengeance. So if you look at this on the left side, which is your side of it, your duty and responsibility include to provide optimal environment both physically and emotionally for the student to return to school or stay in school. And school absolutely needs to have this thing called FND action plan and then continue to work with the student and providers through care coordination. On the right side, this is a treating providers. And that includes something like our program, Teen FND Academy, even though we're not quote unquote treating providers. Once the diagnosis is clarified, then students will be needing to get a proper treatment. And then also providers and or other people who are involved with the recovery of the FND will be involved as a care coordination between the student and you guys school, and all through education, meaning that the providers and school, you guys can educate with each other of how to help the student towards a recovery and resolution of FND, because that is very possible. The other thing about pediatric FND is the prognosis is very, very high as long as they do get the right approach treatment. But if they don't do anything, then prognosis becomes less and less and less. And once they turn adult age or they have been having these FND symptoms for years and years, then prognosis becomes very, very poor. And if you walk away with one thing and one thing only out of this webinar, this is exactly what I need you to understand about FND. You cannot simply treat FND as the same thing as epilepsy. Therefore, epilepsy action plan from the Epilepsy Foundation is widely inappropriate and should not be used to help the student with FND in school. I'm going to give you an analogy. It's like a student falls and gets a bruise on knee and the student looks to be in pain and agony. Let me ask you this. Do you think that this student needs to get an EpiPen? I don't think so. Well, the same rule applies here. Just because two things may look similar, quote unquote, you cannot apply one solution to both situations. What that means is FND is not a medical emergency. That being said, you have to provide a physical safety first because FND may or may not cause a secondary injury of head injury and other things, right? So we're talking about fall risk here. FND is because not a medical emergency, you cannot and you should not call 911 just because a student is having FND unless the student is having a secondary injury. Do not take vitals, absolutely no need. Do not time each episode. It does not matter and it does not help. It is actually detrimental to do any of these things towards FND recovery. Therefore, if you're doing any or all of these things just because a student is having FND, you are being the perpetuating factor for the FND to continue to exist in that student's body. Moving on, do not send students home after each episode. That is not the way to treat and resolve FND. And absolutely do not punish students for having an episode. This is extremely negatively reinforcing, therefore perpetuating the students to have ongoing FND episode. And because it's a team effort, school cannot do this on their own, right? Nobody's asking you to reinvent the wheel, play as a medical provider here. You need guidance, and I am here to give you that. Now, this is a checklist of every school needs to think about and have a plan for each item. What is FND? First of all, do you know what it is? Do you know what is not? As I mentioned, what is the difference between functional tics versus tic disorder? What is the difference between non-epileptic episode versus epileptic seizures? And who is on the team? Who are you working with? And what to do when a student has an episode? You have to have an action plan. You cannot just punish or send the kid to home. And are there any academic accommodation? Or is there any quiet place the student can take a break? Are there any trusted adults on campus that the student can rely on or the family can rely on? Who is the go-to person? When to call the parent? How do you know? When to call 911 and what to do with the peers? All of these things, you need to think about them. But don't worry, I'm going to give you an action plan in a minute. Now, it's also important for you to know the triggers and warning signs for the student's FND. They can be very different depending on the student. Now, one caution is many students may not know the triggers oftentimes. In fact, over 90% of children with FND usually don't know the triggers until they go through a proper treatment. But these are typical examples of what triggers can be. Loud noise or commotions, anything has to do with the stress, not just with the emotional, but physical stress and anxiety, like fatigue and things like that. Any upcoming tests, presentation, any big things going on, any conflict with others, that could be peers, students, teachers, or administrative staff. Are there any worsening pain that can happen before? And the warning signs, body pain might be the beginning sign of having an episode, or feeling off or weird. That is very common. And feeling weak, tingling and numbness hyperventilation. These things are pretty common warning signs. Now, this is a 6 steps of FND action plan that you can include. And number 1, you have to know the detailed information about the student's FND. What do they look like? How often it happens? And what has been the history? This is where you need input from the student and also the provider. And number 2, what the student can do, aka coping strategies to use in school before or on a regular basis for this student. So then how you can help the student to prevent the student from having FND symptom as much as possible. And number 3, during an FND, what are you going to do? What to do during an episode? Number 4, when to call 911, and you need to know when that is and what that is. And number 5, after FND, how the student wants to be supported. You absolutely need to talk about it and then agree upon it. And lastly, note for EMT. So if the EMT is called, then there is an information about EMT who can help you and the student. All of those things are recommended and highly encouraged to be included on that action plan. Sample support pack from the FND Hope website. This is readily available for anyone, including you. And this is how schools can support FND recovery. So I would encourage you to go to their website and download and take a look at them. And this is another sample of action plan, which is different from epilepsy action plan, as you can see. And it has pretty much all of the 6 elements that I talked about. And this is also a sample of classroom strategies a student can implement. And again, they are all free and available on the FND Hope website. So if you as school personnel notice your student may or may not have FND, but there is no formal diagnosis, what can you do to help the family to get the help they need? Here are some examples you can do and say. Number 1, empathy, empathy, empathy. You can say something like, I hear you. I believe you. You must feel XXX, like upset, sad, scared, anxious, uncertain, all of that stuff. Provide empathy so that you can build a rapport and validate. After you go through this empathy, you can also validate. I wonder what is stopping you from getting the help you need. What are the bottlenecks that we can do to help you? You can also explore, like, what would success look like for you and your child after resolving FND? And how would you like to support your child, or how would you like to be supported by your parents? And all of these things are ways for you to explore and validate at the same time with the student and the family. You can also assess, what is your fear? What is your concern? And what happens if nothing changes? And that could be something that they might be dwindling on. And some families may ask for assistive device. And this is what I have to say. Assistive devices are generally not recommended because, remember, FND is not the same thing as a permanent disability disorder. It is absolutely manageable, treatable, if not solvable problem. Therefore, resuming daily activities equals recovery. And that's why resuming the daily functioning is the number 1 priority for any students to recover from FND. And that's why avoiding adapting this mindset of disability will help the students to improve. However, you might have to think about using these devices in a short-term basis, right? So you need to really think about and evaluate the purpose of their use. And you have to secure a support letter from treating providers. So you are not making decisions on their own, jumping the gun, and accidentally perpetuating these symptoms of FND. So you need to be very careful with that. You also want to engage in discussion with the family about the plan. What is, again, the purpose, and what is the plan for using these assisted devices and services? And it is absolutely critical to review progress on a weekly basis, if not more frequent. And what about this one? Should these students with FND even go to school? I mean, after all, it's a lot for school to manage, right? So let's take a look at it. Generally speaking, in-person attendance is strongly advised. Same thing with the assistive device. The regular school attendance supports recovery and returning to school gradually, depending on where the student is at that time of the FND recovery process. It can reduce stress levels for students because a lot of students not going to school in itself can be the source of the stress. However, you also want to be thinking about whether or when the alternative school environment may be necessary. If there is a high level of distress associated with school, which may or may not have anything to do with FND, however, this is something that you need to investigate. And also, if you are not able to offer a safe physical and emotional environment, which would take a lot to say that you're not able to offer, but some circumstances do exist, or you're not able to provide any accommodations for the student. And what about alternative school options out there? And more importantly, can the family have the capacity and resource to support this child if they were to transition the student to the alternative school environment? All of those things are things to think about. And once again, I don't think you can make a decision on your own. Therefore, it requires the team effort of conversation between you, the student, family, and the providers. And if you want more resources for FND, please check out the supplemental website. FND is a real disorder, and your student is not faking to get attention. FND is not just psychological problem, but it is a biopsychosocial phenomenon. And this is why once a student is diagnosed with FND, school needs to work with the family and providers. You cannot do this alone. Taking a wrong approach from a goodness of heart or ignorance will cost you and the student significantly. The first step for you as school can do is to know what FND is, how FND is diagnosed and treated, and work with the family and providers to get guidance. The communication is the real key here to unlock the student's success. The success of not only resolving FND, but also thriving in their lives. And school can be the important piece of the puzzle to make it happen. Thank you so much for watching this video, and leave a comment below to let me know how your experience has been with students with FND.